Hello dear learners, मैं डॉक्टर संगीता चौधरी and I welcome everyone to my lecture class. इस क्लास में चलो डिस्कस करते हैं about COPD. COPD stands for Chronic Obstructive Pulmonary Disease. इसको COAD भी बोलते हैं. COAD means COAD means Chronic Obstructive Airway Disease. Okay, chronic obstructive airway disease नहीं तो chronic obstructive pulmonary disease. So let's see, देखते हैं what is the definition of chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is defined as a disease state characterized by airflow limitation that is not fully reversible. Means COPD में airflow limitation होता है which is not fully reversible. COPD जो है, COPD includes certain different entities of lung involvement. Okay, it includes emphysema, chronic bronchitis and small airway disease. अभी emphysema क्या होता है? Emphysema को define कर सकते हैं a condition characterized by destruction and enlargement of the lung alveoli. Emphysema में destruction होता है alveoli के as well as there is enlargement of the air spaces, enlargement of the alveoli होता है, बड़ा हो जाता है. Chronic bronchitis is clinically defined condition with chronic cough and phlegm, means cough and sputum production. Small airway disease क्या होता है? Small airway disease is a condition in which small airways are narrowed. जो छोटा छोटा airway होता है, small airway, they are narrowed. Okay, so these three, emphysema, chronic bronchitis and small airway disease, combinedly they are designated as chronic obstructive pulmonary disease. रिस्क फैक्टर्स ऑफ COPD. क्या क्या रिस्क फैक्टर हो सकता है? स्मोकिंग इज वन ऑफ द वेरी इंपॉर्टेंट एंड मेजर रिस्क फैक्टर्स फॉर chronic obstructive pulmonary disease. When we see patients in clinics, most of the time they will have history of chronic smoking. Okay, it's the major risk factors. Airway responsiveness. Airway responsiveness जो ज़्यादा होता है, that is airway hyper responsiveness. ओके, नॉर्मली जितना रेस्पॉन्ड करना चाहिए, नॉर्मल पर्सन में एयरवे जितना रेस्पॉन्स करता है टू अ पर्टिकुलर स्टिमुलस, इन दिस केसेस एयरवे रेस्पॉन्सिवनेस बहुत ज़्यादा होता है फॉर दिस ग्रुप ऑफ पेशेंट्स. एंड द सेम थिंग इज सीन विद ब्रोंकियल एस्थमा ऑल्सो. सो समटाइम्स देयर इज एन ओवरलैप बिटवीन द symptoms of or the manifestations of COPD and bronchial asthma. Respiratory infection. Respiratory infection again one of the important factor. Rather I would say respiratory infection जो है, they are important precipitating factors for exacerbation of chronic obstructive pulmonary disease. Many times ऐसा होता है कि patient को stable COPD रहता है, means stable disease रहता है, but they develop certain respiratory infections के वजह से उनका जैसे रेस्पिरेटरी फंक्शन जो है डिप्रेस हो जाता है. COPD becomes exacerbated. स्टेबल डिजीज से सडन वर्सनिंग होता है पेशेंट का एंड पेशेंट प्रेजेंट्स विद exacerbation of COPD. ऑक्यूपेशनल एक्सपोजर भी बहुत इंपॉर्टेंट है अमंग द रिस्क फैक्टर्स. ऑक्यूपेशनल एक्सपोजर में जो लोग कोल माइन में काम करते हैं, उनको जो कोल डस्ट से एक्सपोजर होता है, वो भी एक बहुत इंपॉर्टेंट सिग्निफिकेंट रिस्क फैक्टर है फॉर एम्फाइसेमा. स्मोकर हो या फिर नॉन स्मोकर हो, दोनों में ही दिस इज अ वेरी इंपॉर्टेंट रिस्क फैक्टर फॉर एम्फाइसेमा. एम्बिएंट एयर पोल्यूशन. स्मोक प्रोड्यूस्ड बाय बायोमास कंबशन appears to be a significant risk factors for COPD. Means environmental जो pollution होता है, air pollution, that is also a significant risk factors for COPD. Pathophysiology. Pathophysiology में there will be airflow obstruction, there will be hyperinflation in the airways. impaired gas exchange. So these are the important things in pathophysiology. Airflow obstruction रहेगा, hyperinflation रहेगा airways में, and there will be impairment in the gas exchange. Let's see what happens in the pathophysiology. So this image, it depicts the different triggers for the initiation of the pathophysiology. Trigger में cigarette smoke is very important, as well as genetic susceptibility. That means there should be an interaction between the environmental factor and the genetic factors for the development of COPD. तो जो environmental factors है, environmental factors में जैसे कि सिगरेट स्मोक एक मेजर रिस्क फैक्टर्स है, नहीं तो एम्बियंट एयर पोल्यूशन से, इवन लाइक पैसिव स्मोकिंग से, कोल डस्ट एक्सपोजर, दीज आर द एनवायरमेंटल फैक्टर्स फॉर रिस्पॉन्सिबल फॉर द डेवलपमेंट ऑफ COPD. जब एनवायरमेंटल फैक्टर्स एंड जेनेटिक फैक्टर्स में इंटरेक्शन होता है, देन देयर विल बी इनिशिएशन ऑफ एन इन्फ्लेमेटरी कास्केड. जो इफेक्टर सेल रहता है COPD में, द इफेक्टर सेल्स कैन बी, दे आर मैक्रोफेजेस, न्यूट्रोफिल्स, epithelial cells and lymphocytes. Biological pathway, when these effector cells gets activated, they initiate the inflammatory cascade and they results in various signaling. They release a number of cytokines, then there will be signaling through the cell and certain biological pathways which are involved. Protease, antiprotease pathway, oxidant imbalance between the oxidant and antioxidant, apoptosis होगा, apoptosis is programmed cell death and there will be defective repair in the lung. जो key molecules है, they are like MMP12, Serpina-1, neutrophil elastase, NF-kappa beta, NRF2, SOD3, SOD3, HDAC2, RTP801, ceramide, TGF-beta and elastin. These are the key molecules which are responsible for the ultimate pathobiological result. That is, ultimate result is extracellular matrix destruction होता है lungs में. There is chronic inflammation, cell death, ineffective repair of the lung. Chronic inflammation होता रहता है lung में, cell death होता है mainly because of apoptosis, programmed cell death होता है and lung is getting destroyed and at the same time repair भी नहीं हो रहा है, repair भी ineffective repair होता है. So all these functions together of different cell they functions, then different signaling pathways, different molecules, key molecules, they combinedly do the damage to the lung, ultimately leading to ineffective repair, cell death and ineffective repair. Pathology, large airway जो है उसमें क्या होता है, mucus gland enlarge होता है large airways में and goblet cell hyperplasia होता है. ऐसा होने से there will be release of more mucus, that means increase in production of cough and mucus. Squamous metaplasia of bronchi predisposing to carcinogenesis and disrupting mucociliary clearance. ठीक है, squamous metaplasia होगा bronchus में जो may result in development of malignancy. And because of squamous metaplasia, mucociliary clearance भी disturbed रहता है. Smooth muscle hypertrophy हो सकता है and bronchial hyperreactivity. तो क्या क्या हो रहा है लार्ज एयरवे में, जो लार्ज एयरवे है वहाँ पे म्यूकस प्रोड्यूसिंग जो सेल्स है, ग्लैंड है, साइज बड़ा हो जाता है, दे रिलीज मोर एंड मोर म्यूकस व्हिच रिजल्ट्स इन प्रोडक्टिव कफ. स्क्वामस मेटाप्लेशिया होके मैलिग्नेंसी भी हो सकता है एंड इट डिसरप्ट्स द क्लियरेंस ऑफ द म्यूकस फ्रॉम द एयरवेज. स्मूथ मसल सेल हाइपरट्रॉफी होता है एंड ब्रोंकियल हाइपर रिएक्टिविटी होता है, दैट मे also result in constriction of the airways. स्मॉल एयरवेज में क्या होता है? इन स्मॉल एयरवेज the major site it is the major site of increased resistance. Small airway means airways less than or equal to 2 millimeter in diameter. Small airways में भी goblet cell metaplasia होता है which replaces the Clara cell. तो Clara cell replace होने से क्या होता है? There will be reduction in the surfactant level. जो सर्फेक्टेंट है दे प्रिवेंट एल्वियोलर कोलैप्स नॉर्मली. अगर सर्फेक्टेंट रिड्यूस होता है देन देयर विल बी कोलैप्स ऑफ द एल्वियोलाई लीडिंग टू एटेलेक्टेसिस. मोनोन्यूक्लियर सेल इन्फिल्ट्रेशन होता है इन द स्मॉल एयरवेज एंड देयर इज स्मूथ मसल सेल हाइपरट्रॉफी. मोनोन्यूक्लियर सेल इन्फिल्ट्रेशन होके सेम दे विल रिलीज नंबर ऑफ साइटोकाइंस, इन्फ्लेमेटरी कास्केड को शुरू करता है, इन्फ्लेमेशन होता है. स्मूथ मसल हाइपरट्रॉफी होके देयर विल बी अगेन नैरोइंग एंड इंक्रीज रेजिस्टेंस इन द एयर फ्लो थ्रू द स्मॉल एयरवेज. लंग पैरेन्काइमा में क्या होता है? हम देखिए लार्ज एयरवे में क्या होता है, स्मॉल एयरवे में क्या होता है. अभी देखते हैं लंग पैरेन्काइमा में व्हाट आर द चेंजेस इन COPD. I have already told emphysema होता है. Emphysema क्या होता है? Emphysema is the destruction and abnormal enlargement of the alveoli or air spaces जो ultimately gas exchange को hamper करता है. Okay? In air spaces like respiratory bronchioles, alveolar ducts and alveoli में ये changes हो सकता है. Emphysematous change में involve all these structures. जो एम्फाइसिमा है उसका टाइप्स है. ओके, वन इज सेंट्री एसिनर एंड वन इज पैन एसिनर. सेंट्री एसिनर मीन्स जो एनलार्ज एयर स्पेसेस है दे आर फाउंड इन एसोसिएशन विद रेस्पिरेटरी ब्रोंक्यूल्स. पैन एसिनर मीन्स लार्ज एयर स्पेसेस है, abnormally large air spaces है, they are evenly distributed within and across the acinar units. Pan acinar means whole of the acini is involved. Okay, centry acinar and pan acinar type of emphysema. Diagnosis. अभी diagnosis कैसे करेंगे हम? Diagnosis again it depends on a good history taking and symptoms of the patient, clinical presentation of the patient. कॉमन सिम्टम्स क्या क्या हो सकता है? पेशेंट का सिम्टम्स होगा जैसे कॉमन सिम्टम्स डिस्निया दैट इज शॉर्टनेस ऑफ ब्रेथ, कफ होगा पेशेंट को, स्पुटम प्रोडक्शन होगा इन केस ऑफ chronic bronchitis. Patient will be producing huge amount of sputum usually for 3 consecutive months for last 2 consecutive years. That is the clinical definition of bronchitis. Sputum production for 3 months for last 2 consecutive years. Sputum production and wheezing हो सकता है. Wheezing is musical sound during respiration. Dyspnea on exertion होता है पेशेंट को. जो ब्रीदिंग डिफिकल्टी है वो exertion के साथ में रिलेटेड होता है and it progresses gradually over time. धीरे धीरे ये डिस्निया जो बढ़ जाता है, ठीक है, धीरे धीरे बढ़ता है. This is just a diagrammatic representation. Here you can see the healthy alveoli. Okay, these are the alveoli. यहाँ पे हम देख सकते हैं COPD में कैसे alveoli का destruction होता है. Destruction भी होता है and some of them get dilated also. Healthy in COPD. History. Weight loss often occurs in the end. Okay, जब late stage होता है COPD का तब पेशेंट को weight loss भी होता है. But other etiologies such as malignancies and depression should be ruled out if there is weight loss. On examination, हम जब एग्जामिन करते हैं a patient of COPD तो क्या क्या हमको मिल सकता है? On bedside examination. Patient with severe COPD, there will be prolonged breath sound on a maximal forced exhalation. Okay, decreased breath sound रह सकता है. Air entry decrease हो जाता है, so there will be decreased breath sound on auscultation. Accessory muscle का use होगा. During respiration there will be use of accessory muscle because of increased work of breathing. Chest hyper-resonant होगा on percussion because there will be more amount of air, lung will be inflated because of enlargement of the abnormal enlargement of the airways. Enlarged thoracic volume, expiratory wheezing may or may not be present. So these are the findings on examination. Long-standing COPD may result in pulmonary hypertension, one of the very serious complications of chronic obstructive airway disease. Pulmonary hypertension का sign क्या क्या होगा? And pulmonary hypertension अगर patient को हुआ, then that will ultimately lead to right-sided heart failure. Signs of pulmonary hypertension and right heart failure may be present. What are the signs of right heart failure? Right-sided heart failure. Okay, right-sided heart failure में there will be raised JVP, jugular venous pressure will be raised. There will be pedal edema, presence of pedal edema, and there will be presence of tender hepatomegaly. These are the few signs of right-sided heart failure. Pulmonary hypertension, signs of pulmonary hypertension, PH for pulmonary hypertension. इसमें क्या होगा? On auscultation, in pulmonary hypertension, on auscultation, typically there should be a loud P2. We know that S2 has, that second heart sound has two components, that is A2 and P2. P2 is because of closure of the pulmonary valve. In case of pulmonary hypertension, we may get a loud P2 component of the second heart sound. And we may get a ejection systolic murmur also. Ejection systolic murmur. In case of, if there is development of pulmonary hypertension. Okay. Clubbing is not a sign of COPD. अगर पेशेंट को क्लबिंग है तो we need to rule out other causes of clubbing. Even we may need to rule out bronchogenic carcinoma also, because bronchogenic carcinoma may be associated with clubbing. Okay. Its presence should prompt an evaluation for other condition, especially lung cancer. Because most of the time COPD patients will be smoker, and smoking also confers a high risk for lung cancer. Diagnostic testing. What are the tests we can do? हम pulmonary function test कर सकते हैं. Pulmonary function test में finding क्या होगा? In my other class, I will discuss about pulmonary function test in detail. But here, let's know the expiratory flow limitation on spirometry, and that is suggested by the ratio of FEV1 and FVC less than 0.7. What is FEV1? FEV1 means forced expiratory volume. Forced expiratory volume, 1 means 1 second. What is FVC? FVC means forced vital capacity. Forced vital capacity. So the ratio of FEV1 and FVC will be less than 0.7 in case of COPD patient, and it is suggestive of obstructive airway disease. Airway disease जो दो टाइप के हो सकते हैं, one is obstructive and the other one is restrictive. Obstructive airway disease में FEV1 FVC ratio is less than 0.7, whereas in restrictive disease it may be normal or it may be high also. FEV1 defines the severity of expiratory outflow obstruction, and it is also a predictor of mortality. Okay, so doing a pulmonary test is very important in case of, if we are suspecting a case of COPD. Pulmonary function test से और क्या information हमको मिलेगा? We will know about total lung capacity. Okay, TLC stands for total lung capacity. We will know about functional residual capacity, FRC, functional residual capacity. We will know about residual volume, that is RV. Total lung capacity, functional residual capacity and residual volume, they often increase to supernormal values. क्यों increase होता है ये सब? Because in case of obstructive lung disease like COPD, there will be hyperinflation of the lung. More amount of air will be there inside the lung. Air trapping रहेगा इसमें. तो इसी वजह से all this capacity what I have mentioned, TLC, FRC, RV, all will increase. Diffusion capacity of the lung for carbon dioxide may be reduced. DLCO stands for diffusion capacity of the lung for carbon monoxide. Okay, it is usually reduced in case of COPD. Lab. A baseline ABG, arterial blood gas analysis, should be done to assess the presence and severity of hypoxemia and hypercapnia. Hypoxemia means reduced oxygen, hypercapnia means increased level of carbon dioxide. तो हम ABG करेंगे तो we will know about this hypoxemia and hypercapnia. Elevated venous bicarbonate, it is a metabolic response to chronic hypercapnia. अभी hypercapnia means increase in carbon dioxide, right? It is because of retention of carbon dioxide in the body. Once carbon dioxide body में retention होता है, then it will be converted to carbonic acid. Carbonic acid body में ज़्यादा होगा definitely, then there will be respiratory acidosis. Okay, respiratory acidosis. Respiratory acidosis होने से kidney will try to compensate for it, and then how kidney will compensate? Kidney will try to conserve bicarbonate more, and that's why there will be elevated venous bicarbonate. Okay, there will be elevation of bicarbonate as a result of compensatory renal mechanism. Polycythemia. Polycythemia means increase in RBC and increase in hemoglobin as well as in RBC होगा because of chronic hypoxemia and inadequate supplemental oxygen. ठीक है, तो polycythemia basically it is a compensatory mechanism of body as a response to chronic hypoxemia. अगर ऑक्सीजन लेवल chronically कम रहेगा पेशेंट में and there is inadequate supplemental oxygen use, then ultimately patient will develop polycythemia. Imaging. What are the imaging tests we can do? We can go ahead and do a chest x-ray, okay, as the initial imaging technique. Chest x-ray में हमको क्या दिखेगा? It is usually not sensitive for diagnosis. Basically हम क्यों chest x-ray करेंगे? To evaluate any alternative diagnosis. और कुछ है क्या lungs में? Is it because of COPD or some other thing that we need to rule out? Plus, importantly, we want to rule out if there is any infections also in the lung, because as I have said, many of the time because of respiratory tract infection, the patient will come to us with a worsened COPD or with what we call as COPD exacerbation. Exacerbation. Okay. So, in that case, we need to rule out if there is any infection in the lung. With increasing severity, जब बहुत severe हो जाएगा, then there will be thoracic hyper inflation, lung का hyper inflation होगा, flattening of diaphragm and lung hyperlucency with diminished vascular markings. Okay, हम next slide में इस एक्सरे को देखते हैं. इस एक्सरे देखने से we will know about the changes of COPD in case of, we'll know the X-ray changes of COPD. So look at this chest X-ray. This is chest X-ray PA view. क्या हो रहा है ये chest X-ray में? What is abnormal in this chest X-ray? We can see that the lucency of lung has increased, means it is hyperlucent. अब lucency क्या है? Lucency means the black thing what we see in the lungs. Why lungs are black? Because of presence of air. एक्सरे में जो भी एयर है, जिस बॉडी पार्ट में एयर रहता है वो ब्लैक दिखाई देता है. That is known as the lucency. Hyperlucency means there is increase in the darkness, increased in the black thing. Okay, जो blackening है वो increase हो जाता है in case of long standing COPD. So there is hyperlucency. Lung fields are hyperlucent. Now, if we look carefully, there is flattening of the dome of the diaphragm. This is the left dome, this is the right dome. So, diaphragm domes are flattened. Normally, dome कैसा होता है? Diaphragm का dome, they are usually like this. Okay, doming. They are dome shaped. But यहाँ पे the diaphragms are almost flat. Flattening of the diaphragm. Flattening, okay, flattening of domes of diaphragm. Next thing what we can see that there is widening in between the rib spaces. These in between ribs, these are the rib spaces. Okay, these are quite widened than the normal rib space. Okay, widening of rib spaces. What more we can see in this chest X-ray? We can also see there is reduction in the bronchovascular markings. Bronchovascular markings. Okay. What more we can see? Look at the cardiac shape. Look at the cardiac shadow. It has become almost tubular. Okay, the heart shadow is almost tubular. Tubular cardiac shadow. Okay. Otherwise, how does a normal heart look? A normal heart will be like this. Okay. This is a normal heart, what just now I have drawn. But instead of this, in this particular patient, the shape of the heart is like this. So it is like almost a tubular heart. So these are the findings from which we can know that the patient is having emphysema. Hyperlucency in the lung, flattening of domes of diaphragm, widening in between rib spaces, bronchovascular markings reduced हो जाता है and cardiac shadow जो है वो tubule shape का हो जाता है. Okay, tubular shape. Chest CT is not routinely required for the diagnosis. Okay, assessing patients with severe COPD for lung volume reduction surgery and lung transplantation. इन दोनों केस में हम CT scan of the chest कर सकते हैं. अगर हम पेशेंट को assess करना है, in case we are going to do a LVRS. LVRS stands for lung volume reduction surgery. और हम अगर lung transplantation plan कर रहे हैं, in that time we can go ahead and do a chest CT scan. Treatment goal. What are the goals of treating a patient? To improve the quality of life. Definitely COPD patient का quality of life तो इतना अच्छा नहीं होता है. So we need to improve the quality of life. To reduce the frequency and severity of acute exacerbation. Acute exacerbation means acute increase in patient's symptoms. Acute onset shortness of breath रहेगा, cough रहेगा, hypoxia होगा patient को, okay. To slow the progression of the disease. It is a progressive disease, okay. It progresses with time. तो हमारा aim रहना चाहिए so that we can slow the progression of the disease. Prolongation of survival. So these are the few goals which we should keep in mind before we start treating a patient of COPD. Mortality benefit के बारे में अगर बात करें तो there are only 2 or 3 things which gives mortality benefit to a patient of COPD. Among them, smoking cessation is the most important thing. Smoking cessation, we need to advise the patient. Definitely patient should stop smoking because it increases patient survival chance. So mortality benefit is seen with smoking cessation. Correction of hypoxemia means oxygen supplementation. Oxygen supplementation. अगर हम ऑक्सीजन सप्लीमेंट करते हैं with the correct amount and correct timing, then also we can improve the survival of the patient. Okay, mortality can be reduced. And lastly, LVRS. LVRS stands for lung volume reduction surgery. Okay, so by doing LVRS also we can reduce the chance of death in a patient. GOLD classification of COPD. Okay, what does GOLD stands for? GOLD stands for Global Initiative for Obstructive Lung Disease. So this is important because हम जब ट्रीट करते हैं COPD पेशेंट को, it depends on the staging. Depending on the stage of the disease, we usually treat a patient of COPD. तो गोल्ड क्राइटेरिया जो है ग्लोबल इनिशिएटिव फॉर ऑब्स्ट्रक्टिव लंग डिजीज, गोल्ड ग्लोबल इनिशिएटिव फॉर ऑब्स्ट्रक्टिव लंग डिजीज. तो जो गोल्ड क्राइटेरिया है उससे हम 4 स्टेज में डिवाइड कर सकते हैं COPD पेशेंट्स को. स्टेज 1 इज माइल्ड डिजीज, स्टेज 2 मॉडरेट, स्टेज 3 सीवियर, स्टेज 4 वेरी सीवियर डिजीज. माइल्ड डिजीज में क्या होता है? द स्टेजिंग इज डन डिपेंडिंग ऑन द FEV1 FVC ratio. Okay, we already discussed what is FEV1. This is forced expiratory volume at 1 second divided by forced vital capacity. Okay, depending on the ratio and the level of FEV1, it is staged. The staging is done. Mild case में क्या होगा? FEV1 FVC ratio is less than 0.7. Not only mild, in all the cases the FEV1 FVC ratio is less than 0.7 when it is reduced than the normal. FEV1 is equal to or more than 80% of predicted in case of stage 1. As the stage progresses, FEV1 comes down. जो moderate disease है उसमें FEV1 जो है it will be in between 50 to less than 80. जो severe disease है उसमें FEV1 will be in between 30 to less than 50. Very severe disease में FEV1 30 से भी कम रहेगा. Okay, in very severe disease it is less than 30% of the predicted. So ऐसे हम COPD patients को different stages में divide करते हैं. Okay, stage 1, 2, 3 and 4. Stepwise approach to COPD therapy. As I have already mentioned that COPD patient का treatment depends on the GOLD staging. So if it is a mild stage of the disease, then what we will do? हम advise करेंगे for the smoking cessation. Smoking cessation should be advised for all the patient. Okay, smoking cessation, vaccination against influenza, and against pneumococcus. Vaccination against influenza and pneumococcus are very important. Influenza vaccine जो है that is given yearly. Okay, and जो pneumococcal vaccine है that may be given once in a lifetime or it may be repeated after 5 years. It again depends on the patient's profile. Short acting beta agonist हम use कर सकते हैं like salbutamol. मॉडरेट डिजीज में क्या करना है? ऑल ऑफ द अबव. तो माइल्ड डिजीज में हम जो करते हैं, स्मोकिंग बंद करना होता है, वैक्सीनेशन देना होता है पेशेंट को, शॉर्ट एक्टिंग बीटा एगोनिस्ट ऐड कर सकते हैं. अलोंग विद ऑल दीज थिंग्स वी कैन यूज अ लॉन्ग एक्टिंग ब्रोंकोडायलेटर. ओके, लॉन्ग एक्टिंग ब्रोंकोडायलेटर. लाबा. लाबा स्टैंड्स फॉर long acting beta agonist. So long acting bronchodilator में we have long acting beta agonist that we can use. We have aminophylines also, but then they are arrhythmogenic, so they are less preferred. Pulmonary rehabilitation हम कर सकते हैं. Okay, severe case में all of the above what we are doing in moderate disease plus patient को inhalational corticosteroid दे सकते हैं. Okay, if patient has repeated exacerbation and oxygen if needed. Most of the time at the severe stage they will definitely require oxygen, so oxygen हमको देना है patient को. Very severe stage में all of the above जो हम severe stage में करते हैं सब कुछ हमको करना है, plus we may refer the patient for surgical management. Okay, what is known as LVRS I have discussed, lung volume reduction surgery. इसके लिए we may refer the patient to the surgeon. Medication. Okay, चलो medication के बारे में जानते हैं. What are the medication and what dose we use, when we use? Inhaled bronchodilators. They prevent an increase in airway smooth muscle tone. Airway smooth muscle tone को they reduce करता है. That means there will be द कंस्ट्रिक्शन जो होता है एयरवेज में वो रिलीव कर देगा. देन देयर विल बी डायलेटेशन ऑफ द एयरवेज. एडिशन ऑफ टायोट्रोपियम इम्प्रूव्स लंग फंक्शन, क्वालिटी ऑफ लाइफ एंड COPD exacerbation. Tiotropium is one of the anticholinergic agents which we can use. Inhaled corticosteroids increase FEV1 and it reduces exacerbation, लेकिन लंग फंक्शन जो है इसका जो डिक्लाइन हो जाता है, धीरे धीरे लंग फंक्शन रिड्यूस हो जाता है, दैट इट डज नॉट स्लो द रेट ऑफ डिक्लाइनिंग लंग फंक्शन. FEV1 इंक्रीज करता है, रिड्यूसेस एक्सेजर्बेशन बट डू नॉट अपीयर टू स्लो द रेट ऑफ डिक्लाइन ऑफ लंग फंक्शन ओवर टाइम. Combination therapy. Combination of ICS stands for inhalational corticosteroids. Okay, inhalational corticosteroids plus long acting beta agonist. Long acting beta agonist में what we have? We have long acting beta agonist means LABA. Okay, LABA stands for long acting beta agonist. In that we have salmeterol and formoterol. These are the two long acting beta agonist agent. ठीक है, तो combination of inhalational corticosteroid and long acting beta agonist is effective in reducing the rate of COPD exacerbation, but there is increased risk of pneumonia because हम steroid use कर रहे हैं. तो steroid is actually it suppresses the immunity, तो pneumonia होने का chance रहता है patient में. Long acting beta agonist plus long acting anticholinergic. Long acting anticholinergic like tiotropium can be combined with salmeterol or formoterol. They cause ये greater increase करता है in FEV1. Short acting beta agonist plus short acting anticholinergic agent, they causes greater increase in FEV1. शॉर्ट एक्टिंग बीटा एगोनिस्ट जैसे मैं बोल चुकी हूँ, शॉर्ट एक्टिंग बीटा एगोनिस्ट. SABA stands for short acting beta agonist. One example is salbutamol. Salbutamol, albuterol. Okay, these are the short acting beta agonists. Most commonly used short acting beta agonist जो है वो salbutamol है. So combination of salbutamol plus short acting anticholinergic agent जो है वो greater increase करता है in FEV1. I was talking about aminophylline. Theophylline का indication है patient not improving adequately to inhaled bronchodilator therapy. तब we can use theophylline. Intravenous alpha-1 antitrypsin administration. Alpha-1 antitrypsin deficiency जो है that may also lead to emphysema. So intravenous alpha-1 antitrypsin administration, weekly infusion of 60 mg per kg. That is a specific treatment अगर patient को alpha-1 antitrypsin deficiency है तो. Other supportive thing like what we can do, we can give supplemental oxygen. और जैसे मैं बोली कि oxygen is one of the 3 component or 3 measure which we can take to improve patient survival. Oxygen, supplemental oxygen has mortality benefit, decreases mortality and mental functioning in hypoxemic patient. Mental functioning क्यों? Because अगर hypoxia हो रहा है तो brain में भी problem होगा. Okay, hypoxia may induce permanent brain injury. तो mental functioning will be improved in case of hypoxemic patients अगर हम supplemental oxygen देते हैं तो. Pulmonary rehabilitation. Pulmonary rehabilitation करना है patient का. Okay, that will also help the patient. Improvement of symptoms. Vaccination. Vaccination करना है. Annual influenza vaccination I have mentioned, and every 5 years pneumococcal vaccination देना है. Surgical management. Surgery में क्या करना है? Lung transplantation is the ultimate option we have for severe COPD. Lung transplantation करते हैं तो it will improve the quality of life and improve functional capacity. Though lung transplantation is not available in all the center, okay, in very few centers the facility for lung transplantation is available, and of course it is very costly. Selection criteria. Board score of 7 to 10 or at least one of the following. History of hospitalization for a COPD exacerbation associated with acute hypercapnia, or else pulmonary hypertension, right heart failure or both despite supplemental oxygen therapy. Third one is FEV1 less than 20% and either a DLCO, that is diffusion capacity for carbon monoxide less than 20%, or homogeneous distribution of emphysema. Along with the positive board index, as I have mentioned in the last slide, along with the positive board score of 7 to 10 and at least one of the 3 criteria which I have mentioned, अगर ये positive है then हम patient को we can prepare the patient for surgery. Lung transplantation. LVRS, lung volume reduction surgery, provide quality of life and survival benefits in patient with, not in every patient, सब patient में lung volume reduction surgery नहीं कर सकते और helpful भी नहीं होगा. तो जिनको upper lobe emphysema है and significantly reduced exercise capacity है, उनमें this lung volume reduction surgery is helpful. It improves the quality of life and it also provides survival benefit. MMRC. ये MMRC क्या है? MMRC stands for Modified Medical Research Council Dyspnea Scale. MMRC, Modified Medical Research Council Dyspnea Scale. Why we need to know that? Because ये जो Modified Medical Research Council Dyspnea Scale है, इससे हम we can actually grade the stage of the disease, grade the dyspnea in a patient of COPD. Provides a single number for degree of breathlessness. 0 means breathlessness only with strenuous activity. ठीक है? 1 means hurrying on a level ground or walking up a slight hill. 2 means walks slower than peers or stop walking at their own pace. 3 means walking about 100 yards or after a few minutes on level ground. Patient develops breathing difficulty on walking about 100 yards or after a few minutes on level ground. 4 means patient is too breathless to leave the house or when dressing, means patient is breathless even at rest. So ये even history लेने के time में भी this is important. अगर history से we can define at which stage the patient is, stage 2 or stage 3, we know the severity of the disease. Severity assessment, कैसे patient का severity assessment करना है. Okay. Exacerbation history, more than or 2 or more exacerbation or 1 or more exacerbation with hospital admission. 0 or 1 exacerbation without hospital admission. COPD severity group. C means, let's start from A. A means low severity, okay, low symptoms, low risk. B means high severity, low risk. C means low symptoms, high risk, and D means high symptoms, high risk. This MMRC stands for what just now I have described, Modified Medical Research Council Dyspnea Scale. Okay, it is 0 to 1 or CAT less than 10. CAT stands for COPD Assessment Test. MMRC more than or equal to 2 or CAT, that is COPD Assessment Test, is more than or equal to 10. Okay. So this is how we grade the COPD severity. अगर patient को more than or equal to 2 exacerbation history or more than or equal to 1 with hospital admission है, plus patient का MMRC is more than or equal to 2 or CAT more than or equal to 10 है, then patient will fall into category D, that is the worst case. If patient का hospital admission नहीं है, 0 to 1 exacerbation history है and MMRC 0 to 1 है, नहीं तो CAT less than 10 है, then patient will fall into this category. Okay, category A, low symptoms, low risk. So this is how we do the severity grading in case of COPD with help of exacerbation history and symptoms of the patient. If we talk about the management as per the severity category, okay, group C, okay, group C we can use LAMA plus LABA can be used if there is further exacerbation, or as LABA plus ICS can be used. Okay. Group A, bronchodilator is used. Evaluate the effect, then we may continue, stop or try alternative class of bronchodilator if the patient is not improving. Then ग्रुप बी में क्या करते हैं, a long acting bronchodilator that is LABA or LAMA we can use. Persistent symptom है तो we can combine them. LABA and LAMA can be combined. Okay. In group D, LAMA-LABA combination, LAMA, LABA, LAMA and LABA combination, or else LABA plus inhalational corticosteroid, that is ICS, can be used, or all can be combined like LAMA, LABA, ICS, all can be combined if there is further exacerbation. उसके बाद भी अगर exacerbation हो रहा है, further exacerbation, then we may consider roflumilast if FEV1 is less than 50% predicted and there is chronic bronchitis. अगर persistent symptoms है या फिर further exacerbation है, then we may consider macrolide also in former smoker patients. So this is how we grade the severity, and depending on the grading of severity we may treat the patient of COPD. I was talking about board index. What is board index? There will be, I will not go into the detail, but there are 4 variables in the board index, that is FEV1, distance walked in 6 minutes, MMRC, dyspnea scale, and body mass index. And 4 categories of score are given, 0, 1, 2, 3. The board index help us to decide whether the patient will be benefited with surgical options or not. If board index is in between 7 to 10, plus some other criteria are followed that I have already discussed, ये सब fulfill होता है, then we may refer the patient for surgery. Acute exacerbation of COPD. Acute exacerbation क्या है? Acute exacerbation means increase in breathing difficulty, often accompanied by increased cough, increased sputum production, purulence of sputum, presence of wheezing, chest tightness, or other symptoms of acutely worsened respiratory status. In the absence of an alternative explanation, defines a COPD exacerbation. What does it mean? इसका meaning है patient will present with acute worsening of respiratory symptom. Breathing difficulty होगा, acute cough होगा, sputum production होगा, wheezing, chest tightness, सब acute symptom होगा patient को, and we will not be able to diagnose or we will not be able to give any other alternate explanation other than COPD. तो उसमें उसको हम बोलेंगे patient has come with COPD exacerbation. Cause is most of the time respiratory infection and sometimes air pollution also. Differential diagnosis क्या होगा? Any condition, respiratory condition which may have acute presentation may be a differential diagnosis of COPD. Pneumothorax, pneumonia, pleural effusion, congestive heart failure, cardiac ischemia and pulmonary embolism. So these are the differential diagnosis for acute exacerbation of COPD. In almost all these cases patient will present with acute onset of shortness of breath होगा patient को, tachypnea भी हो सकता है, okay, cough रहेगा patient को. Treatment कैसे treat करते हैं हम COPD exacerbation? We will give a short acting beta agonist. This is the first line of treatment. हम systemic corticosteroid use करेंगे. Acute exacerbation में systemic corticosteroids are needed. Antibiotic therapy use करेंगे because I said most of the time the precipitating factor is infection, mostly bacterial infection. Okay, so antibiotic therapy देना है and supplemental oxygen अगर saturation, अगर SpO2 और oxygen saturation is below 90%. So to maintain, our target will be to maintain the SpO2 more than equal to 90%. So in that case, we will have to give supplemental oxygen. Non-invasive ventilation करना है. अगर patient is not improving with simple oxygen supplementation with nasal cannula or nasal mask, in that case, nasal cannula or face mask, in that case हमको non-invasive ventilation करना पड़ेगा. Okay. Non-invasive ventilation, if patient responds to it, it will reduce the intubation rate. क्या क्या करता है non-invasive ventilation? It improves respiratory acidosis, it decreases respiratory rate, and it decreases the length of hospital stay as well. इसका मीनिंग है पेशेंट का इम्प्रूवमेंट जल्दी होता है एंड हॉस्पिटल लेंथ ऑफ स्टे रिड्यूस होता है. अल्टीमेटली इफ अगर पेशेंट नॉन इन्वेसिव वेंटिलेशन से भी इम्प्रूव नहीं हो रहा है, देन फाइनली वी हैव टू गो फॉर endotracheal intubation and invasive mechanical ventilation. Okay, that is the last option we have. Complication, this is the last thing I want to discuss. Complication of COPD. Chronic long-standing COPD में patient will have pulmonary hypertension and right heart failure. There will be increased risk for lung cancer, pneumothorax, arrhythmias and psychiatric disorders like anxiety and depression. Sleep disturbance रहेगा almost in 50% of the patients. So हमको complications के बारे में भी aware होना है so that we can prevent the complication. और अगर complication develop हो चुका है then we need to definitely manage and treat the complication. So यही था about chronic obstructive COPD disease और COPD और COAD, जो मैं इस क्लास में डिस्कस करना चाहती थी. थैंक यू.